could you make some comment about those who have more of a urethritis?
For us, scientifically, this is an important area that we humbly tell everyone we have not sorted out yet. Okay. However, we're using artificial intelligence more and more and more in our service, but we've used Bayesian methods, which are the core of artificial intelligence much more, and we use those techniques to look for clusters inside our patient populations. So a while ago, I sent our data set raw off to some Professor Maria Diorio, who is a professor of statistics at UCL and runs a Bayesian unit. And one of her PhD students did his doctorate on those data. And without me saying anything at all whatsoever, they picked up a cluster in the clinical presentation. Now, we run a slightly similar analysis, but on our treatment choices, because we use trial and error elimination. We start a treatment. Does it work? Is it tolerated? And keeping very, very careful records. By trial and error, you just evolve. And we found that there are a group that were selecting for tetracyclines and macrolides. Now, Maria's group said this cluster has a lot of urethral pain and low white cell counts compared to the epithelial cell counts. We then looked at our data and found that the cluster of macrolides and tetracyclines that were selected were low white cell count, higher urothelial cell counts, and urethral pain as a characteristic. So we're at a situation now where that group exists. We've done a further study to check it, and it does. So there's a subgroup that have particularly urethral pain, but not exclusively, a lower white cell count and a higher urothelial cell count, who appear to respond to tetracyclines and macrolides better than anything else, but not always, not necessarily the case. Now, macrolides and tetracyclines raises the option of obligate intracellular microbes. Now, the most famous is chlamydia, and in our big studies, we didn't find chlamydia in our patients or in the controls, but we did find mycoplasma, other molecules, Legionella. So at this moment, we're in the process of developing, well, we're not developing, we're just getting to work a pretty difficult technique that involves us extracting the cells from the patient and then putting in a DNA probe into the cell. Attached to that is a fluorescent marker so that we can get inside the cell, bind that probe to any microbes that might be sitting there, and thereby identify them. And that way we're hoping to study this group compared to another group to see if we can catch the obligate intracellular microbes in flagrante. But at the moment, we're based on the data that I just given you. And the other thing that's coming out is that group take a long, long, long time to get better. We're developing much more sensitive measures of symptoms in order to allow clinicians to track these patients. Because if you've got a score that's improving, then you know that you're on the right track. But at the moment, our scores are not crude enough to pick up some of the more subtle elements. So we're going to do that by artificial intelligence and with the help of the patients' organizations. But yeah, and you've got to be so patient, so patient.